And we're now going to move on and look at bone healing and what exactly is involved in the process of bone healing. To point out first some of the key points with bone healing. So 10% of fractures following traumatic injuries do not heal properly, and we'll explore that towards the end of the presentation after we've looked at what happens when there's normal bone healing. And bone healing involves two main phases, which is the anabolic phase and the catabolic phase. The anabolic phase is first, and this involves increased tissue volume to form new skeletal tissues, and it's followed by a prolonged catabolic phase, which involves tissue remodeling and bone resorption. And this is to get the bone back to its original structure. So fracture healing is very much regulated by the nature and extent of trauma and the stability of fracture fixation and biological processes. So that's our own body's immune system and the development processes associated with the skeletal ontology. So to pick up on those at anabolic and catabolic, the point that I made in the last slide, so bone and fracture repair can be considered as consisting of anabolic, which is quite simply the bone forming, and catabolic, which is bone resorbing. Now these very much work in conjunction with one another. However, the anabolic bone forming begins first off. And I have a graph on the next slide to show you these processes. So prior to these, so when there isn't a fracture and there's no injury, these processes run at low levels. So they're in a state of hemostasis. So there's always ongoing bone turnover and remodeling, and this continues even when there isn't a fracture. For example, if there's micro damage to bones, then these will come into play as well. So just to point out, volume and time, the anabolic phase begins first, and then this will initiate the catabolic phase, which happens after. So the anabolic phase dominates and precedes the catabolic removal of unwanted tissue and bone resorption with subsequent remodeling. These are the stages of bone healing, which we'll look at more in depth. So inflammation is what happens first, similar with wound healing, that we pointed out in the wound healing slide. Inflammation happens first 6 to 8 hours post-fracture. We then have the reactive phase, and this can last about 3 weeks. The reparative phase, depending on the severity of the fracture, this can last up to 3 to 4 months, and then remodeling phase. So to look at these individually, we'll do that now. So inflammation and the reactive phase. So when an injury occurs to the bone, the inflammatory phase happens first off. And the formation of a hematoma generates the production of cytokines and growth factors. We think of the inflammatory phase with wound healing. This is effectively no different. So we have our chemotaxis and our cytokines, prostaglandins, histamine, and bradykinin, all required for the phases of fracture healing as well. The cytokines that are necessary to recruit stem cells, which then become chondrocytes, which are needed for bone formation. The initial injury that initiates the inflammatory is necessary for the healing phase to continue. And that the hematoma that coagulates in between the injury site and around the fracture that forms a callus formation. And at this point there's numerous blood vessels throughout the bone which have now become damaged due to the injury. And due to those now dead blood cells around the bone, this causes more cells to enter at that site based on the healing cascade. While pro-inflammatory cytokines have a negative effect on bone when prolonged or in chronic expression, for the likes of this process, it is crucial, the inflammation is crucial for tissue regeneration. So we have a blood clot formation, and due to those dead cells and if we think of the wound healing as well, we have our macrophages and in the case of bone, osteoclasts, which are needed to remove devitalised tissue, and cells which are dead around the area of injury. And this process can last several weeks. In line with inflammation as well, we also have the cardinal signs of inflammation, so our redness, pain and swelling at this injury site. The reparative phase and the granulation tissue formation, which forms procallus, so that at the site of injury there's new blood vessels that grow into the hematoma, which was formed in the last stage, and this begins to organise into granulation tissue formation, or procallus. This procallus will then form the fibrocartilage callus, and why we need the fibrocartilage callus is because it is the temporary formation of fibroblasts and chondroblasts. And this is needed to form, to secrete collagen and to form the extracellular matrix around the fracture site. So fibroblasts from the periosteum and the osteogenic progenitor cells from the periosteum and red bone marrow start to invade. So whenever they start to invade that procallus, they change it into the fibrocartilage callus. Collagen produced by the fibroblasts then become chondroblasts, and these connect the two ends of the fracture together. The chondroblasts secrete the main components of the extracellular matrix, and therefore plays a vital role within this phase. The osteogenic progenitor cells produce osteoblasts, which are needed for bone formation. And at this stage what we have is a trabecular spongy bone formation, which is also known as woven bone. Woven bone is a random organisation of collagen fibres, and it's described as being mechanically weak. So therefore at this point you can still put no stress on the fracture, as we're still going through the healing process. Within the remodelling phase, and that woven bone, which is arranged into a dense and spongy bone arrangement, so it has an equal amount of mechanical function as well as a metabolic function. Now the woven bone, at this point we need the woven bone to become mechanically strong. Therefore, in order to achieve a mechanically strong bone, the fracture healing cascade initiates a second resorptive phase, and it does this in order to remodel the woven bone into a lamellar bone structure, which is mechanically strong. The woven bone is then removed gradually by the action of the osteoclasts, and if we think of the anabolic and catabolic, the osteoclast is involved in that catabolic phase, and this is replaced by osteoblasts to form the lamellar bone, which is, as said, is mechanically strong. The remodelling process is carried out by a balance of woven bone resorption of osteoclasts and the lamellar bone deposition of osteoblasts, and it needs to be done within tight regulation. For example, if there's too many osteoclasts that remove too much bone, then the end result will be the end result will mean that the bone isn't as mechanically strong. And we'll look at this whenever we move on to things that can potentially go wrong with fractures and fracture healing. This process, and it probably goes without saying that the process of fracture healing is faster in younger patients. So to recap and to look at it with this diagram, we initially have our hematoma formation, as we've discussed, which happens with our inflammation and that reactive stage of fracture healing. Then we have the fibrocartilage callus and the granulation tissue formation, so the new blood vessels, the spongy bone trabeculae, which is the woven bone. We also have external and internal callus and the fibrous tissue and cartilage. And this then moves on to a bony callus formation. So the two middle images are a reparative phase. And the bony callus of spongy bone during or that woven bone then moves into the lamellar bone structure, which is mechanically strong, and within that bone remodelling phase. So despite the regenerative capacity of skeletal tissue, the biological process sometimes fails, and fractures may heal in unfavourable anatomical positions, or show a delay in healing, or can develop pseudoarthrosis and non-unions. So what we're going to look at now is the complications of fracture healing. There could be malunion, delayed union, non-union, avascular necrosis or osteomyelitis, which all have an impact on how the bone heals. We will look at these individually. When we look at the terms malunion and delayed union, both of these terms fall short of constituting a diagnosis or specifying the underlying processes. And what might be the case within a malunion or delayed union is an anabolic deficiency or catabolic excess, or both happening in conjunction with one another. The anabolic deficiency may be caused by high energy fractures or extensive surgical procedures. And what might happen here is that there's obviously, with anabolic deficiency, this means that there's insufficient new bone formation, and such an injury will compromise the vascular supply of the bone and surrounding tissue. The return of the vascular supply within the area of the fracture site is necessary for final repair and the magnitude of the initial vascular injury, and this will determine the level of damage that's occurring. On the opposite of this, you might have a catabolic excess, which is premature and or excessive resorption of callus or original bone. The catabolic response may be responsible for insufficient callus during bone repair, and therefore may subsequently cause the malunion. Both of these can also happen with one another, and within this you will have insufficient bone formation as well as excessive resorption, which then will essentially lead to the bone and the fracture not healing correctly. Avascular necrosis. Avascular necrosis happens when the blood supply is interrupted to the bone, or the joint becomes dislocated. It is essentially the death of bone tissue due to lack of blood supply. It's also known as osteonecrosis, and it can lead to tiny breaks in the bone and the bone's eventual collapse. There's a lot of things that can cause avascular necrosis, but one of the main things is it's associated with long-term high-dose steroids and excessive alcohol intake. And with the high-dose steroids, what is believed to happen is that it causes hypolipidemia, and within that it reduces the blood flow and therefore leads to avascular necrosis. Excessive alcohol intake can also cause fatty deposits within the blood vessels, and therefore can subsequently cause lack of blood flow to the area of the fracture. There's different things that will also cause avascular necrosis and that will cause poor healing of fractures, which we'll look at in a later slide. Osteomyelitis, and this is something that we see whenever, for example, if someone has peripheral vascular disease, possible ulceration, diabetes and foot ulceration, and it can often be caused when there's bone exposed and then infection of the bone. The most common organism to cause osteomyelitis is Staph aureus. It can also be caused by other organisms, but this is including strep and Pseudomonas. Most infections, including osteomyelitis, are caused by bioforming bacteria. So if we think back to the slide on wound healing and that biofilm and the bacteria being encased in a matrix and able to work better together to cause that infection. The severity of the osteomyelitis is staged on the infection's etiology, the pathogenesis, the extent of bone duration, the duration of the osteomyelitis, and the host factor, in particular the individual patient. So if there is peripheral vascular disease, if there's diabetes and potential neuropathy, then this will increase the severity of the osteomyelitis. Because it affects the bone and it's an infection of the bone, it's obviously going to have a major impact on the process of normal fracture healing. If we think back to that inflammatory slide, and where I mentioned that inflammation is needed, but if there's chronic inflammation due to something that is causing it, like an infection of the bone, it's going to have a detrimental effect on the bone healing. And just an image of osteomyelitis. So this osteomyelitis was caused by a tissue break. Therefore, because the skin is broken, it allows for a portal of entry of infection, and this is the bone's been exposed, and therefore the infection or the bacteria is being allowed to harbour on that bone and then cause osteomyelitis. And this is other things that factors that influence bone healing. So we have mentioned our systemic corticosteroids, and in particular the prednisolone, that is thought to cause or have an impact on bone healing. Also diet, if patients have or people have a deficiency of calcium and vitamin D, this is going to have an impact on bone healing. Smoking is going to cause the fatty deposits, therefore having an impact on the blood supply to the site of injury. If somebody has had a gastric bypass, this is going to impact on calcium absorption as well as vitamin D absorption, which is going to also have an impact on bone healing. Diabetes, where we potentially have peripheral vascular disease, neuropathy is going to have an overall impact on healing as well. So this is a final slide on factors influencing bone healing and things that we haven't discussed. Although we have touched on some of these that are systemic corticosteroids, in particular our prednisolone, which potentially causes hypolipidemia, and therefore has an impact on the blood supply that's going to the fracture site. Diet, if there's nutritional deficiencies or if there's a lack of calcium or vitamin D, this is going to have an impact on healing. And with diet and gastric bypass as well, they're quite similar in terms of the deficiencies. A gastric bypass may cause calcium or have an impact on calcium absorption as well as vitamin D absorption. Smoking and nicotine in particular is thought to decrease the rate of fracture healing, and it inhibits the growth of new blood vessels, and therefore this has an impact on bone remodelling. The non-steroidal anti-inflammatory drugs are believed to Finally, just to point out, I have added some key papers on the hub for further reading, and those key papers that I've used for the presentation. And this is on the Talus link on the wound healing tab on the hub site. Thank you.